Hello, I'm Dr. Wala Eldin. Welcome to the MRCP Part 2 High Yield Revision Series. Let's get started.
Welcome to Dr. Wala Eldin Ahmed's lecture about bronchiectasis. Today, we are diving into bronchiectasis, one of those conditions that sits right at the intersection of physiology, pathology, and hands-on clinical management. Before we begin, this lecture is generated for educational purposes and exam preparation. It is not intended as a substitute for professional medical advice, diagnosis, or clinical guidelines. By the end of this session, you will understand exactly why the airways dilate, what drives the destruction, and how we recognize and manage it, both at the bedside and in the exam hall. Let us begin. Before we talk about what goes wrong, we need to appreciate what goes right. The respiratory tract is beautifully designed. Airways branch from the trachea down through the bronchi and bronchioles, each lined with a remarkable defense system, the mucociliary escalator. Think of it as a living conveyor belt. Cilia, tiny hair-like projections, beat in a coordinated wave, sweeping mucus and trapped particles up and out of the airway. This is the first line of airway defense. When it works, pathogens never get a foothold. But when it fails, and we will see several ways that can happen, the consequences are profound. Here is the central concept you must lock in. Elastase leads to tissue destruction, leads to dilation. It is that simple, and it is that important. Keep that sequence in mind as we move through every pathway in this lecture. There are two major roads to bronchiectasis. They look different at first, but they arrive at exactly the same destination. Let us take the infectious pathway first. Certain pathogens are particularly destructive. We are talking about Staphylococcus aureus, Klebsiella species, and Mycobacterium tuberculosis. Here is how the damage unfolds. These pathogens trigger a neutrophil recruitment response. Neutrophils arrive as first responders, and they release elastase and reactive oxygen species. Now, this is the key concept. That elastase is meant to fight bacteria, but it does collateral damage. It destroys the epithelial cilia, the smooth muscle, and the elastic tissue of the airway wall. Mucus accumulates, chronic infection takes hold, and the airway wall, deprived of its structural support, undergoes permanent dilation. Now, the immunological pathway. Here, the problem is the opposite. The immune system is too weak, not too aggressive. Low immunoglobulin levels mean the body cannot clear pathogens effectively. The result? Repeated episodes of pneumonia, chronic inflammation, progressive bronchiolar wall destruction. Notice something important about distribution. In the immunological pathway, where disease is systemic, we tend to see diffuse involvement. In the infectious pathway, damage is often localized to the lower lobes. But the endpoint is identical. Chronic inflammation leads to airway wall destruction, leads to permanent dilation. Both roads lead to the same place. Now we add three more pathways, all converging on the same catastrophic endpoint. Mucociliary leads to chronic infection, leads to bronchiectasis. First, physical blockage. A tumor or an inhaled foreign body. A classic example is a peanut in a child. Physically obstructs the airway lumen. Cilia cannot propel mucus past it. Stasis occurs, bacteria colonize, infection follows. Second, cystic fibrosis. Here, the mechanism is functional, not mechanical. A mutation in the CFTR gene produces abnormally thick, viscous mucus. The cilia are intact, but the mucus is so heavy they simply cannot move it. Chronic mucus plugging, persistent infection cycle, progressive airway destruction. Third, and critically important for your MRCP exam, primary ciliary dyskinesia. An autosomal recessive mutation results in absent or defective dining arms on the cilia. Dining arms are what power the ciliary beat. Without them, cilia move randomly or not at all. The mucociliary escalator fails, mucus accumulates, infection takes hold. Remember this rule: obstruction can be mechanical, as in a foreign body, or functional, as in CF or PCD. And for your exam, cystic fibrosis and primary ciliary dyskinesia are the two genetic causes you must know. Bronchiectasis does not stay confined to the airways. It has consequences that reach the heart. Here is how it happens. Chronic inflammation leads to bronchial wall fibrosis. That fibrosis spreads beyond the airway wall. We call this peribronchiolar fibrosis. Scarring extends into the surrounding lung tissue. The gas exchange area falls. Widespread damage means widespread hypoxemia. Now the lungs respond. In areas of low oxygen, pulmonary arterioles constrict, redirecting blood toward healthier zones. This is an adaptive response. But when damage is generalized, that vasoconstriction becomes generalized too. Resistance throughout the pulmonary circulation rises. This is pulmonary hypertension. The right ventricle now faces massively increased afterload. It hypertrophies. Eventually, it fails. And when the right heart fails because of lung disease, we have a specific name for that: cor pulmonale. Here is the key concept to anchor this slide. The lung damages the heart, not the other way around. Damage pathway. Chronic inflammation leads to fibrosis, leads to hypoxemia, leads to pulmonary hypertension, leads to cor pulmonale. Read that sequence. Learn that sequence. It will appear in your exam. Now, let us bring this to the bedside. How does a patient with bronchiectasis present? The first and most consistent feature is a persistent cough. Severe. Ongoing. The body's attempt to expel what the airways can no longer clear on their own. The second, purulent sputum. Thick, foul-smelling mucus. Why foul-smelling? Because bacteria have colonized those dilated airways. This is not just inflation, it is active infection. Third, haemoptysis. Coughing up blood. This occurs when small blood vessels adjacent to the inflamed airways are damaged. In bronchiectasis, haemoptysis is common and in severe cases can be significant. Fourth, breathlessness and cyanosis. As gas exchange falls and blood oxygen drops, the patient becomes breathless. In severe or advanced disease, cyanosis. Now, how do we confer the diagnosis? The investigation of choice is high-resolution CT of the thorax. Look for dilated bronchi and the pathognomic signet ring sign. What is the signet ring sign? The bronchial diameter is greater than the diameter of the accompanying pulmonary artery. In a normal lung, they should be roughly equal. In bronchiectasis, the bronchus has expanded, and that size mismatch is your diagnostic clue. We also use pulmonary function tests, which typically show a reduced lung capacity and reduced forced expiratory flow, an obstructive pattern, sometimes with a restrictive component. And when there is clinical suspicion of a genetic cause, we send for genetic testing for PCD or cystic fibrosis. Clinical Pearl. Commit this to memory. Chronic productive cough plus dilated airways on CT. That is bronchiectasis until proven otherwise. Treatment targets 3 pillars: infection, mucus clearance, and obstruction relief. Let us walk through each. Antibiotic therapy. The goal is to target the recurrent bacterial infections driving the inflammatory cascade. We use oral or inhaled antibiotics. Inhaled preparations give us direct airway delivery with fewer systemic side effects. Common pathogens we target include Staph aureus, Klebsiella, and in the right clinical context, Mycobacterium tuberculosis. Breaking the infection cycle prevents further airway wall destruction. Postural drainage and percussion. This is the cornerstone of daily management. The patient is positioned to allow gravity to assist drainage from specific lung segments. Manual chest percussion loosens mucus plugs. In cystic fibrosis patients, special physiotherapy protocols are used. Hypertonic saline is also valuable. It thins the mucus, making it easier to clear. This must be done daily. Surgical intervention, reserved for localized disease only. When a tumor or foreign body is causing obstruction, or when medical therapy has failed, resection of the irreversibly damaged lung segment may be considered. Combined approach, infection, mucus, obstruction. Treat all 3. And that brings us to the end of this session on bronchiectasis. We have covered the physiology of normal mucociliary defense, the multiple pathways to airway destruction, infectious, immunological, obstructive, and genetic, the cardiovascular complications that follow widespread disease, the hallmark clinical features, the role of HRCT as our gold standard diagnostic tool, and the 3 pillars of management: antibiotics, airway clearance, and surgical intervention where needed. And we tested your knowledge through 5 MRCP-style questions, each one targeting a different dimension of this condition. Key messages to carry with you. Elastase is the primary driver of structural airway destruction. PCD and cystic fibrosis are the genetic causes to know. HRCT is the diagnostic gold standard. Look for the signet ring sign. The lung damages the heart. The pathway is fibrosis to hypoxia to pulmonary hypertension to cor pulmonale. And postural drainage is the cornerstone of daily management. Thank you for your attention. Good luck in your revision, and I will see you in the next session.
If you found this video helpful, I'd really appreciate it if you subscribe to the channel for more high-yield MRCP Part 2 revision content.